Well, hi everyone. Thank you for joining this session on navigating menopause with confidence. I'm Lori Novarita from the Academy for Continued Healthcare Learning, joined today by our faculty, Dr. Rachel Cady, and this is provided by Responsum Health and the Academy for Continued Healthcare Learning. This is supported by an educational grant from Astellas Pharmaceuticals. And I'm happy to transition right now to our faculty, Dr. Cady, to walk us through the presentation today, as well as some Q&A at the end. And we did receive some questions from folks pre-registering for the session, so I'm happy to share those. There's also a poll that has hopefully just appeared on your screen, if you can take a moment to answer those few questions. But we'll get started now with Dr. Cady, if you can share a bit about yourself and then move into your presentation. Thank you.
Great. Yeah, good afternoon, everybody. My name is Dr. Rachel Cady. I'm a OBGYN and I'm a certified menopause practitioner, and I'm the director of our Menopause and Healthy Aging program in Central Minnesota. So I'm coming to you from there. So I am really excited to visit with all of you and answer as many questions as I can. I think, the title of this talk, Navigating Menopause with Confidence, is something that's really relatable to many of us and many of the patients that I have the pleasure of seeing every day, because many of them are just trying to navigate, what's real, what isn't real, what's gimmicky, what's this fear factor sometimes people are having, what are people's individual symptoms, what's menopause, what isn't menopause, those kind of things. So given that the average woman spends about 40% of her life in menopause, that it's important to kind of get the information, and the saying of women make good decisions when they have good information, I think is largely true. So as far as, what menopause is, there's two types of menopause, really. There's surgical menopause when the ovaries are removed. And then there's the natural menopause when ovaries stop producing estrogen. And the average age of menopause in the United States is 51 to 52. So on this graph here, on the left-hand side, you'll see on the y-axis the estrogen level. So, pre-menopause is when our ovaries are still working, we're still ovulating, cycles are still occurring. And then typically, usually late 30s, early 40s, mid 40s is when women start experiencing perimenopausal symptoms. And we'll get into what some of those symptoms are here in a bit, but most commonly will be some cycle irregularity, meaning ovaries are not necessarily ovulating every month. There's wild fluctuations in estrogen levels. And so people's symptoms are oftentimes very menopausal, like hot flashes and those kind of things that we'll talk about here in a little bit. And the average duration of those symptoms are quite long, 7 to 10 years ballpark, and so before menopause actually occurs. And again, menopause is the absence of a period for 12 months. So, and at that point, that's when you're menopausal. Looking back, that's the time of your last period. So you have to go 12 months without having a period. And at that point, there is no further estrogen production from the ovaries. And at that point, you are officially postmenopausal. Now, a lot of women will say, oh, I went through that already. Maybe they're 60 years old. I went through that already. Well, you're either premenopausal or postmenopausal. That's kind of what we are. And so that transition, menopause transition that we talk about, really is that time frame between perimenopause and menopause. So we can go on to the next slide here. So how do you know if you're menopausal, for example, or how soon you'll be in menopause, meaning when the ovaries are done functioning, when there's no further estradiol production? And so there are some tricky nuances to this, like if somebody's had an endometrial ablation, for example, or hysterectomy or whatever, so we can talk about those things. But in general, the biggest thing is patient's history. If there isn't uterus present, when was their last period? And if it was greater than a year ago, then that person is in menopause. But some blood tests that can be helpful, again, depending on the scenario, but that your provider, your clinician might order, would be an estradiol test. That's the type of estrogen that's made by our ovaries. Follicle stimulating hormone, that's a hormone made by our pituitary gland in our brain that's trying to stimulate the ovaries to work. So a menopausal woman will have a very low estradiol level and a very high follicle stimulating hormone, or FSH level, because the pituitary gland is saying, come on, why aren't you working? Why aren't you working? We'll send more message. Well, the ovaries is done at that point. And then there's a hormone called anti-Mullerian hormone, or AMH. And this kind of gives us an idea of how much gas is left in the tank, if you will, for ovarian function. And so a postmenopausal woman will have essentially no anti-Mullerian hormone, meaning ovaries done functioning. And so that can be a little bit helpful in predicting time frame before menopause occurs. We also use this in women who are trying to achieve pregnancy over age 35 to get an idea of how much ovarian reserve or how much ovarian function they have left. So those are a few hormones. Now, many of you have maybe seen some of the home test for menopause, and I was just doing a quick search last night on this. And basically what these home tests are measuring is FSH. That's your follicle stimulating hormone. And I would give a little bit of caution about that test because one is the prices were all over the place. And two, a woman who's in perimenopause, if her ovaries are working at all, maybe she's only getting a cycle every few months, but that FSH level is going to be all over the place. So I would say in most cases, the home tests are not going to be particularly helpful and are probably going to be pretty confusing. And the ones I was looking at last night were actually in the range of a couple $100, but I think there's a wide range of them, but I really would be cautious about that because interpretation is going to be hard to kind of do anything with. There's also saliva home test, and those do not have any value. So this is pretty common as far as when I have the pleasure of seeing patients who are coming in just really trying to figure out what's what. And there's 60 attributable symptoms to menopause. And so, when we're doing a consult for these patients, it's usually about an hour long, but we have them fill out. There's a symptom form for menopause because everybody's a little bit different, although there's certain things that are way more common than others. So, these are some of the things that you'll hear women say, that they were having trouble sleeping, they were having some weight gain, they were asking for help and not really getting it or being dismissed. We know that about 80% of graduating internal medicine and OBGYN residents will say that they get no training in menopause. So it's really important, to not dismiss your symptoms, to start tracking your symptoms. So weight gain is a big thing that people will notice. But I first started experiencing symptoms 4 or 5 years ago, but I didn't know it was perimenopause. Started having sleep issues. I've always been a great sleeper, and I started having bouts of insomnia. So just a lot of fatigue, waking up throughout the night, having a hard time getting back to sleep, maybe starting to have some hot flashes. Then I started having these hormonal migraines, which can be more common in perimenopause. And they occurred every month, right around my period, right before or during or afterwards. I didn't necessarily think it was perimenopause. I thought maybe it was stress, so this goes on and on with that, just trying to navigate what's what. And then the weight gain started happening. So we know that these are very common symptoms. In menopause transition, the average woman gains, studies show, anywhere from 5 to 10 pounds, and on average 1 to 2 pounds a year. So that menopause transition really is when women a lot of times are the most symptomatic, but they're still having periods maybe sporadically. So they understandably think, well, this isn't menopause, what could it be? So we can go to the next slide. There we go. So here are some of the more common symptoms of menopause. So we talk about hot flashes. We'll get into that a little bit more, and night sweats, which Night sweats are hot flashes that just occur at night. And collectively, we call these vasomotor symptoms. So if you hear that term vasomotor symptoms, that's talking about hot flashes and night sweats. Vaginal dryness, sleep problems, forgetfulness. We hear about the brain fog. And in particular, that's in areas of verbal recall problems like forgetting somebody's name, forgetting, losing your words when you're talking. Another sort of forgetfulness thing is if there's learning new processes. Those are kind of the areas that are associated with that brain fog of perimenopause. Headaches can occur, and that quote was talking about around the period time, and that's when our estrogen levels are really, really low. So sometimes women will get menstrual migraines. Irritability, anxiety, tiredness, and again, as far as looking across a woman's lifetime, poor sleep, higher risk for sleep apnea, that kind of stuff is very much associated with perimenopause. And any degree of night sweats as well will not get you that good REM sleep. So we know that is huge, huge, huge. A lot of times people will notice kind of more stiff joints. They're wondering, that just takes a while to kind of get going in the morning, which is a lot of times a big change for people. Back pain, urinary incontinence. Again, these are wide ranging, doesn't apply to everybody, but these are some of the more common symptoms. Heart palpitations is kind of an interesting one. And I know that Oprah has even talked about that. And so that is more common in menopause, but it does warrant workup. Weight gain, as I was talking about before, memory changes. I was kind of mentioning that as well. Hair and skin changes, and we'll say that's not necessarily for the positive. People start having a little bit of hair loss and skin changes as far as less deposits of fat underneath our skin and subsequent wrinkles. Change in sex drive. And again, if you look across a person's lifetime, perimenopause in particular is a really high risk time for women to be noticing. And usually it's more of a low desire, just not having the same desire they had before. And that can be really bothersome. So these are kind of some of the more common symptoms that women can experience. So people just need to get an explanation about what's most bothersome for them, some of the biology behind it, and talking about some of the treatment options, which is one of the main goals of this talk. So, what is a hot flash? And for most people, the way it starts out is centrally, kind of, within our core, like our chest area. And it's not usually a very pleasant feeling. It can be associated with anxiety. Oftentimes after this, there'll be chills, usually sweating. Some people even get visibly red face, sweating through their clothes. And understandably, this is quite bothersome to people. About 80% of women experience hot flashes. And so the obvious question is like, well, why? What is a hot flash? And again, that other term for it is vasomotor symptoms. And so basically in our brain is our hypothalamus. And interestingly enough, that's where our temperature regulatory center is. And so when estrogen actually helps to control our temperature regulation in our brain, a hormone is a chemical that has a role in all of our organ systems. So that's why we have so many of these different potential symptoms when estrogen levels are either all over the place with perimenopause or they're consistently low with menopause. So that's why there's, every organ in our body, estrogen has a role in. And so that's what a hormone is. So when there's no longer estrogen, our temperature regulation is oftentimes really out of whack. And the average duration for hot flashes, we'll get into this a little bit, but it depends to some degree on somebody's ethnicity. And so, but it's years, and it's important to treat because we know now that untreated hot flashes is actually not only uncomfortable, but it goes on for years. There's great treatment, and also untreated hot flashes is a risk factor from some heart disease and probably some mental status changes as well. So it's important to treat, in addition to having disrupted sleep is a huge risk factor for other health problems. So women sometimes will just feel warm or they have to kick off the covers at night, that kind of stuff. But ranging all the way to soaking the bed, it really doesn't matter how severe they are, but if they're occurring, they need to be treated. And that's about 80% of women. So I was just talking about this a little bit. How long do vasomotor symptoms last? Again, vasomotor symptoms being hot flashes, night sweats. And all women pooled together is around 7-ish years. But interestingly enough, Hispanic women, it seems to be longer, 8 to 9 years. African American women, longer still, at 10-ish years. Women who experience premenopausal symptoms, like who are particularly affected by PMS or even more severe, something called premenstrual dysphoric disorder, they tend to have symptoms even longer. So this isn't something that just goes away. And even when I was in training, is kind of dismissed as something that just goes on for 1 or 2 years, and how bad can it really be? But now, over the last really handful of years, we're really starting to understand that this is not good. It's not only just a quality of life thing, which is certainly important, but it's also affects people's anxiety, affects people's weight, affects people's sleep, productivity. There's a lot now going on with menopause in the workplace and can be really treatable. So why wouldn't you treat? So again, these are things that go on for a long time. And it's important to note too that for 10 to 20% of women, hot flashes can go on for lifelong. So that's really a thing. So, as far as what are the long-term implications of menopause, as I was saying, a hormone is a chemical that affects all of our organ systems. And in this case, with menopause, we're talking about estrogen. So when there's no longer estrogen, you'll get different symptoms from different areas of the body. And so estrogen is actually good for our heart. I know there's been some mixed messages about that, but estrogen is good for our heart. And so when our estrogen levels decrease with menopause, typically there's some cholesterol changes that occur. That LDL, the bad cholesterol, goes up a little bit. Sometimes triglycerides go up a little bit. Blood pressure goes up a little bit. These are things to really be proactive about. And cardiovascular disease in women is actually going up. It was the theme of this year's World Menopause Day, which occurs in October. And that cardiovascular symptoms in women can also be quite subtle. So to be aware that when that menopause transition is occurring, again, going from perimenopause to menopause, that's a time to, really be checking in with your doctor and being a little bit proactive about that. Our bones have a big need for estrogen. Estrogen keeps our bones strong. And so when we don't have estrogen year after year after year, bones can get quite thin. About half of women in their lifetime will sustain osteoporosis fracture. That's when the bones get brittle. And so osteoporosis is preventable and it's treatable. So certainly being on calcium supplementation, if you're not getting enough in your diet, which is about 1,200 milligrams a day, along with vitamin D and along with weight-bearing exercises, those are great preventive things. Considering being on estrogen if you're in menopause and don't have contraindications, and also realizing that there's a lot of treatments for osteoporosis. This is something that's, I think, relatable to a lot of us. As I was saying, when surveyed, 80% of graduating residents from internal medicine residencies and OBGYN residencies say that they really didn't get training in menopause care in particular. So it's not uncommon that people will get misinformation, whether it be on the web or from their own clinicians. So perimenopause was never even brought up by my female physician or by my female OBGYN, and I started figuring it out on my own. So this is a common journey for women, I would say. Unfortunately, I found out about it through Instagram and Facebook. And not all that's bad. There's some really good resources out there, but I think it's just getting the right resources, because we know that menopause products, which a lot of them are awful or waste of money. It's a multi-billion-dollar industry. So to not really be taken for a ride with that. Then I finally found somebody through the North American Menopause Society who actually listened to me and took my concerns seriously. And I think this is, a really good resource to look at. Now the North American Menopause Society is called the Menopause Society. That's referenced here at the end of the talk, menopause.org. And you can just put in your zip code and find who in your area is a certified menopause practitioner. And so I think that that is oftentimes a great place to start. And there's also some wonderful information on that website, great videos. It's just a great resource for people to reference, both for physicians, but also for patients. So let's talk about the treatment of menopause here. I'd say that this is a common story. If we can get the video to play.
So my initial symptoms regarding perimenopause, I did start with hot flushes many years ago. They were very sporadic, so it was one maybe every 6 months. And then as the time progressed, additional symptoms started. So it started, my breasts became very tender, almost during the time when I was pregnant. And they would fill breast milk and you could barely touch them. So that started gaining weight, which I never had a problem losing weight before. Now I cannot seem to lose the weight. Mood swings was another huge thing. Brain fog. Somebody explained to me that it was like menopause was eating your brain cells, which I thought was a very good explanation. I felt much more anxiety and anxious at times. And then my biggest complaint was my sleep issues. The sleep changes were the most bothersome problem, and it fluctuated a lot. There were times when I could not sleep at all. I would literally be up until 5 o'clock in the morning and would finally fall asleep. I would sleep for maybe 2 hours, and then I was up like ready to go. There's been other times where I sleep for an hour, I'm awake. I sleep for another hour, I'm awake. And then there's other times where I just sleep too much. The hot flashes was the all-time telltale. My mother had gone through menopause very, very badly. So I watched her. So I had experience with that. So, going through the hot flushes definitely was my first sign. And then when I went to my OB/GYN doctor, I wasn't really given too many options. I went to my primary care. She drew some blood work to see if I was in menopause, and it came up that I was still in perimenopause.
That's a really common story. And a lot of my patients are they're well educated and they realize that they don't feel themselves and they're just trying to be proactive about feeling better. So let's talk about treatment of menopause related symptoms. And so this, again, there's 60 attributable symptoms to menopause potentially, and everybody's a little bit different. But when we specifically talk about those vasomotor symptoms, hot flashes, the gold standard treatment is estrogen. And so hormone therapy is typically about 1/4 the dose of what's in a low dose birth control pill. This is a very tiny amount of estrogen, and we can go into that more, but there's all different ways to take that. That is the gold standard. And when somebody takes estrogen, they also get some of the other benefits, as we were talking about a little bit, as far as with heart, bones, those kind of things. We'll get into that a little bit later. There's prescription treatments as well. So there's other FDA approved medications that are prescriptions that are non-hormonal for treating hot flashes, vasomotor symptoms. There's non-prescription therapy as well. We talk about lifestyle type things. That's at the bottom of the triangle, or the pyramid, sorry. Mind, body, and behavior. Sometimes cognitive behavioral therapy in particular is very helpful for anxiety and for sleep. There's actually some really good online programs for that through the Cleveland Clinic. But lifestyle modifications would be, keeping the fan on, keeping the room cooler, sleeping with breathable clothes, having clothes in layers, that kind of stuff. But for a lot of people, being on some sort of prescription or hormone therapy tends to be the most helpful. As we're talking about lifestyle changes, maintaining a healthy weight, and this is just going to come up over and over and over again. And so that weight fluctuation in perimenopause into the menopause years is real. We know that metabolism does go down. Sometimes that's partly because of lifestyle. Most of us are not exercising as much as we did in our younger years. I know that's kind of a broad statement and everybody's a little bit different, but anything that you can do to keep moving, standing desk, weightlifting is really a big thing because a muscle cell burns 4 times as many calories as a fat cell. And it does not have to be massive weights, but getting in 3 days a week as a goal of some resistance exercises, weight-bearing exercises, getting your heart rate up. You hear about 150 minutes a week of where your heart rate's actually going up with exercise. And maybe that's just a quick 15-minute walk at work, just getting up from your desk or whatever, doing your meetings with walking, something. It becomes more important. In general, women need to cut about 400 calories from their diet to maintain. So when my patients say, I'm doing all the same things I did, a couple of years ago, but I just cannot stop gaining weight, I believe them. I totally believe them. But we also know that treating hot flashes and sleep problems is huge in the menopausal population because patients who are having poor sleep, they have high cortisol, that's our stress hormones. It gets harder to lose weight, tend to get insulin resistance, also harder to lose weight. So treating those, important things really does make a difference. Doing things that you enjoy too, anything that's related to movement is great. Wearing layers of clothes, smoking is really tough on our heart and everything else, but certainly with hot flashes as well, staying hydrated and avoiding some foods that can kind of sometimes trigger hot flashes. What are hormone therapy options? So again, the main thing that we'd be talking about is estradiol, which is, there's different types of estrogen, but estradiol is probably the more preferred one. That's the type of estrogen that our ovaries make. And women who do not have a uterus, their uterus was removed with hysterectomy. When we talk about hormone therapy, we're just talking about estrogen, and they do not need progesterone. The point of progesterone is not to treat hot flashes. It's just to prevent the lining of the uterus from getting too thick. So if somebody has a uterus, they want to be on hormone therapy, they'll be getting estrogen and some sort of combination of progesterone or progesterone type medicine so that the lining of the uterus stays thin and that they don't bleed. And there's also bioidentical hormones that can be a little bit misleading, but that just means hormones that are most closely aligned with what our body normally makes. And so estradiol would be that. Prometrium is a type of progesterone that is most closely related to what our body makes as well. And so there's oral forms of estrogen. There's also patches, gels, creams, and sprays. And we think that there's probably some advantage to using a transdermal, meaning a skin applied estrogen, because it bypasses the liver and probably doesn't increase risk of blood clots, or if it does, it's markedly minimal. There is even a vaginal ring that is for hormone therapy. And then there's different types of progesterone and progesterone type medicines. So we can go to the next slide here. So what are contraindications for hormone therapy? And there are some, and fortunately for these patients, there are good non-hormonal treatment options. So I definitely don't want to dismiss these individuals. You know, you got to treat the individual. So somebody who has known or suspected or history of breast cancer, personal history of breast cancer. Family history of breast cancer is not a contraindication. Second would be somebody who has a history of uterine cancer. That is controversial about using hormone therapy in these individuals. Anybody who's had a blood clot. Now, there's some nuances with that, but somebody who's had, in particular, an unprovoked blood clot, you know, or maybe they have a clotting disorder. That's the next thing there. And so that can be a blood clot to your legs or your lungs. Those are very stroke. That's all very serious. Anybody who's had a heart attack, also contraindicated in some cases of severe liver disease, and in some cases of migraine with aura. Many of us have heard about the Women's Health Initiative that's called the WHI study. And it's actually, you know, you can even go to the website still, but that the recruitment for those patients started about 30 years ago. And that was actually meant to be more of a heart study for menopausal women. And the average age of those women was actually 63. So 10 plus years past the age of when we're starting women on hormone therapy in general, but actually went up to age 79. And so, you know, in 2002, the study was stopped because there was an increased risk of breast cancer and blood clots in those patients. But what's confusing for women, and rightfully so, and for clinicians too at the time, is that, you know, there was this big panic and everybody went off of their hormones because of headlines, really. But it's important to note that the average age of those patients were 63 years old that they were being started on. And we know that that's, there's a timing thing with this, and we'll get into that. And also the adverse events were, you know, they're placed on the horse urine, Premarin, Primpro stuff, which we think is probably more detrimental to breast tissue. And the estrogen-only group did not have an increased risk of breast cancer. But again, these were much older women on average, and they were put on the least preferable regimen of hormones. And yet they had a little bit more blood clots and breast cancer, but way overblown. So this study was not designed to determine the effects of hormone therapy for treating menopausal symptoms. It's more for heart disease and things like that. And it determined that hormone therapy should not be used to reduce risk of chronic diseases like heart disease, stroke, cancer, and dementia. So in general, the take-home message with all this stuff, and it is a little bit confusing, there is more information on that menopause.org website. There was an awesome update about this in 2022 about hormone therapy. So we've come a long way. There's more information now. Women younger than age 60 or within 10 years of menopause, with a low to average risk of cardiovascular disease and breast cancer, the benefits of being on hormone therapy way outweigh the risk of being on hormone therapy. So that is really, really important to know. And what do the experts say? And this is referencing the Menopause Society position statement from 2022, where they took all the studies on hormone therapy and benefits and risk and all that kind of stuff. And so in general, you know, women without contraindications, who are within 10 years of the onset of menopause. And so, like I said, some women, the average age is 51 to 52, but you can go up to age 58 before you start menopause. I mean, that'd be an extreme, but that is true. And so 95% of women are menopausal by age 54. So anyway, within 10 years of menopause, younger than age 60, starting hormone therapy at that time, that there's more health benefits than risks. And we can listen to the rest of her story here.
So unfortunately, my medical history prevents me from taking any kind of hormone therapy. When I was 18 years old, I was in a bed practice with my boyfriend at the time, and I've had multiple surgeries from about a year after the accident. I had to have a double knee surgery. And with that, I developed deep vein thrombosis in my right calf. And I had to be hospitalized, was put on Coumadin, and I was told from that point that I would not be able to go on any hormone medications in the future. I agreed to put me on for a medication called Cady, which is an antidepressant, but it has been scientifically shown to help with hot flashes and the mood swings and everything else. A lot of women I've read on going through menopause and perimenopause were taking this and it helped them. So I have been on that for a few years now. I actually didn't think it was helping me, so I did stop it and only to find out it was helping me. So I am back on that. I'd had another healthcare provider suggest bioidentical hormones. I had gone through some research of that, talked to my primary care regarding that. She did not feel that was a good fit for me, considering my medical history. And basically, we've just been trying any kind of over-the-counter medications.
So what are some of the non-hormonal options? And there are SSRIs as a class of medications of antidepressants. Paroxetine, also brand name is Paxil, is the one that seems to have a lot of evidence for that does help to decrease hot flashes quite significantly. Venlafaxine also, that's a little bit of a different type of antidepressant, but is also used for control of hot flashes, vasomotor symptoms. That's brand name is Effexor. There's some nerve pain medications. Gabapentin is commonly known as Neurontin. A really exciting one is this. It's the NK3 receptor antagonist. Like, well, what does that mean? So fezolinetant, brand name is Veoza, is also an excellent non-hormonal option. Would be an option for this individual, from what I can tell from her story. And so it basically blocks the effects of a chemical that kind of makes our temperature regulation all off kilter, and it tends to work quite fast, actually. Another option that's been used by dermatologists for years is oxybutynin, which is actually a really old bladder medication, commonly known as brand name of Dixtrophan. But this used in lower doses than what's used for the bladder twice a day can be very effective for treating hot flashes. Dermatologists have used it for patients who have a lot of issues with sweating. So these are all excellent other treatments. So I'm talking to your healthcare provider. And, sometimes it can be really hard when people have all sorts of symptoms and they don't even, they just know that they don't feel themselves. A typical visit for a clinician is, it's pretty short. It's 15 to 20 minutes. And so the more, concise that you can be, the better. So really trying to take a moment to organize your thoughts, and even getting, information like hopefully from this webinar, but also from some of the resources that we're going to give you at the end of the talk here to at least start the process. Again, the average woman spends 40% of her life in menopause, so it does behoove us to really be proactive. This sets the stage for our health for the rest of our life. So you're worth it. So you have to be your own advocate. Nobody is going to help you. And you really need to do your research. So that's basically what the bottom line is with that. And also ruling out less common, other causes like that can come up, thyroid diseases, autoimmune problems, those kind of things. So at least getting your symptoms on paper and being concise with that. Keep a log of your symptoms. So when you go to the doctor, you can say what you're experiencing, whether it's on a daily basis or weekly basis, just something that's different for you. Strategies to talk to your doctor. There is a website called My Menoplan Symptom Tracker, and I've looked at this as well, and it is quite helpful. It really kind of hits on the symptoms that are most common, and so to you start tracking what your symptoms are that you're noticing. Share your symptoms and question lists. Be clear about your goals. If your big thing is that you're just tired of gaining weight and sleeping awful, say that. I mean, it really, both those things are really big things that really affects everything else. If you don't feel like you're being listened to, then you need to get another opinion. Take notes or bring a family member. I really encourage my patients, if they have a significant other, to bring that person with them, because sometimes there is some effects with relationships. And so knowledge is power, and that's great. Repeat back what you heard. This is a lot of stuff to navigate. And so it's kind of a whole new thing, but it's something that even just taking one symptom at a time. Use your patient portal to view notes and ask questions. That's a good one. So resources that I want to just at least highlight, this can get you a really good start on what's real, what isn't. These are all, medical, very from the horse's mouth, if you will, resources. These are the people that write the guidelines, that do the studies, all that kind of stuff. So you're not going to be misled or asked to buy something. So menopause.org, again, that's our medical society for menopause medicine. It's excellent. I'd also say actually the International Menopause Society as well. Speaking of women's health is from the Cleveland Clinic, and it's very updated on different areas related to menopause, perimenopause. You can search whatever symptom is most on your mind, whatever questions most on your mind. Madam Ovary is an excellent website as well from one of the menopause practitioners out of Yale. My Menoplan symptom tracker can be quite helpful as well. And if you're a podcast person, Dr. Lauren Stryker has an excellent podcast on, and it's just, you can kind of pick the episodes that most pertain to your symptoms, but she really hits on awesome aspects of menopause and gives you the most updated information, and is just really great to listen to. You Are Not Broken is a podcast by, her name is Dr. Kelly Casperson. She's a urologist. This tends to be more in the arena of vaginal dryness, low desire, orgasm, things like that, but also talks about up-to-date treatments, very medical. The people that she has on are all the people that are at her conferences, again, the big researchers. I think it's a very well done podcast. So that is plenty of sites to at least get things started. So I hope that's helpful. And I think too, we are going to maybe get to some questions.
Yes, thank you so much, Dr. Cady, for your presentation. We do have a few questions that have come in from the audience, the pre-registrants, so I'll go through those now. But I think Responsum Health is also opening up the chat in case we have additional questions in these last 10 minutes here. But starting off, someone is requesting to know some of the effects of perimenopause on mental health with already existing behavioral and mood disorders.
Okay, that's actually a great question. And so when you look across a woman's lifetime, a very high risk time for experiencing mental health concerns is in that perimenopause transition. And again, most commonly, that's women in their 40s. And although there is some variation with that, but and that's actually a big area of research. And Dr. Mackey, Maki, is probably the biggest researcher with that. And some of that is also on that menopause.org website, as well as Responsum for Menopause app. But in particular for anxiety. And so if women have experienced issues with mental health prior in their life, they are at particularly increased risk of experiencing worsening symptoms during this time frame. So recognizing that in particular for anxiety, to some degree, depression, irritability, but certainly for anxiety, and being very proactive with that. I was talking about cognitive behavioral therapy, CBT. Most mental health individuals do offer that. Cleveland Clinic actually has excellent program too. If you just Google or search Cleveland Clinic stress management, and also Cleveland Clinic sleep program. It's online, pre-recorded for a minimal amount. Excellent, but being very, very proactive, really looking at your sleep, things like that. Being aware that it's don't ignore it. And so usually it's temporary, and a lot of times hormones can be helpful as well.
Another person is asking if you can touch on the differences between, or maybe pros and cons between DHEA versus hormone replacement therapy.
Right. So there is a lot going on with DHEA. A lot of places you can buy it over the counter or at health food stores. DHEA is a hormone made in our body, and it breaks down into a type of testosterone and into a type of basically estrogen. And so the problem is that the data is lacking as far as how best to navigate that. And so it at this point in time is really not recommended for routine use. There is something similar to DHEA that is available for prescription for what we call genitourinary syndrome of menopause. Most people talk about vaginal dryness or discomfort with intercourse, and that's like a DHEA. It's called prasterone. But so routine use of DHEA is still not recommended. We just don't know. And also it's varying amounts that people are getting. More is not necessarily better. So there's not really great guidelines on that yet.
And one question that just came in is, could you touch on a little bit more testosterone?
Yeah, for sure. So testosterone actually is a hormone women have. We need testosterone. Testosterone's great. But that actually our testosterone level starts to go down in our late 20s, but it kind of plateaus. And so testosterone is actually one of our sex hormones too. It works on our sex, our prefrontal cortex, which is our sexual desire center in our brain. There's also testosterone receptors on the opening of the vagina called the vestibule. And so many women in perimenopause and menopause, as I was saying, will describe, I just don't have a desire for sex. I could care less. I used to, I don't now. It's a problem for me. I wish it was better. Those are kind of just sort of quick questions we'll ask people. So we'll check testosterone levels, and if in vast majority of cases, it's quite low. And so there is a global consensus statement, and you can actually just looked this up on the internet, global consensus statement regarding testosterone replacement in postmenopausal women. And so there's no pharmacy company that makes testosterone replacement for women, but the global consensus statement is, and this is from all the medical societies, is that giving postmenopausal women 1/10 the dose of what a man would get for testosterone replacement can be quite helpful for treating low desire, or what we call HSDD, or hypoactive sexual desire disorder. So these things, the pellets and all that kind of stuff, is not recommended. Those are injectables and that. This is transdermal, meaning it's a cream or a gel that you rub in daily. And the goal is to get people at around the premenopausal level, the upper quartile of normal. So more is not better. That's why pellets are really scary and they're expensive and it's not recommended. But yeah, there is definitely a role for testosterone.
Thank you, Dr. Cady. Another
Yeah.
question that came in, is there a particular length of time that is safe or recommended to take HRT? I've seen everything from not more than 2 years to there are no real limits.
Right. No, that's a great question, and actually particularly applicable because there's a big article that just came out this month on that. So, we used to say, years ago, lowest dose for the least amount of time, and that is not necessarily true. So when we're talking about hormone therapy, the big thing, and that was a big part of this talk, is timing of starting. So within 10 years, that's different than timing of duration. And so, bottom line is, if you have somebody who doesn't have any if there's a patient who doesn't have any contraindications to continuing on hormone therapy, there's really not a reason to have to take them off. We know that when women go off of hormone therapy, they no longer have that bone protection. They don't have the benefits of vaginal results, although there's some other things with that, vaginal health. And a lot of times women just feel better on it. Now, so there's not an upper limit of normal. And that was a study that just came out this month, actually. And so you're right. There's not, sometimes people will be like, well, do I even need to be on it? I'm 70 years old. I feel great. If they want to go off of hormone therapy, or at least see if they can go off of it, I really have them wean off over, several months. And in some cases, they'll be like, you know what, my hot flash just came back right away. Not for everybody, but there's not an upper limit to that, provided no new contraindications. Now, if somebody has a heart attack or 75 years old, something like that, they should go off of hormone therapy.
And someone's wondering, what are some natural ways that they can combat the brain fog, memory loss, and loss of libido?
Right. Okay. So natural ways. So the biggest thing with brain fog is to know that one, it's real. It's a big area of research right now. There's 2 areas of the brain that actually shrink. We see that on MRI to a degree in perimenopause. But there's compensation. It's temporary. Knowing that it's not dementia, or if there's greater concern for dementia, that you'd be evaluated, but that's fortunately quite rare. So the biggest thing really is being aware that it's real. You need to write down a lot more notes than you used to have to do. If there's a new computer upgrade in your at your work, they need to be patient with you and like, hey, this is actually a real thing. But also I keep coming back to sleep, but it's actually completely true. And also looking at the other medications that you're on and making sure that there's no side effects with that. But those are big things. It kind of comes down to lifestyle, which I know is not necessarily obviously the greatest answer sometimes, but really if you're having hot flashes, especially at night, getting those treated, being patient with yourself. Don't expect that you're going to remember, because you very well might not. That's okay. It's not dementia. Write things down. That's for the brain fog. For the low libido, this is a whole discussion in and of itself. I think, as far as there's a lot more with this on that, because there's just so many aspects of this, but that You Are Not Broken podcast, for example. But we know to have good desire, you need to have great blood supply to the genitals and good nerve supply to the genitals. And so when there's not estrogen, there's less of that. And so using some sort of vaginal moisturizer, some sort of vaginal estrogen, which is not the same as hormone therapy. Clitoral stimulators are very helpful. There's some websites that are from OBGYNs that are not creepy or whatever. It's meant to be evidence-based. One is called OMG Yes for further information. Arginine is something too that you can buy over the counter that helps to increase blood supply to the genitalia. This goes kind of on, but those are just a few things.
Wonderful, thank you. Well, I know we're at our time today, but we really appreciate your presentation, Dr. Cady, and responding to some of the questions that have come in. So I want to thank you so much for your time. We're also getting a lot of echoes of thank you from the audience today. And also, again, just want to thank Responsum Health, and I'm with the Academy for Continued Healthcare Learning on developing this education, supported by a grant from Astellas. We're pleased to have the opportunity to share all of this with you today.